Hello and welcome to Eden's Group Training Center. My name is Karen Edens and I'll be working with you as your instructor as we proceed through this course. It's a real pleasure for us to be able to bring to you a hybrid format of the particular course that we're going to be looking at, serving the clients with co-occurring disorders. You should have a number of handouts in front of you. I'll be talking about those in a few moments. But what I'd like to do is also review with you just a bit of the logistics of this course and how it's going to unfold. First of all, it is a 12-hour course. And the reason that it's a 12-hour course is that is what is required by the Minnesota Department of Human Services licensing division as it relates to program requirements. People working in substance use disorder programs are expected to be able to document 12 hours of continuing education in this particular subject area. What I've done is I've taken the 12 hours and it's been now broken up for you into 4 3-hour modules. Each of the modules are going to be made up of an hour and a half of lecture material that will be sent to you so that you can view that at your leisure. And then each of you will also have an hour and a half assignment that you're expected to complete following the lecture module. When you've completed the assignments, again, the expectation is that you'll submit those to me, Karen at Eden's Group. And my email address is indicated on the screen. And I would like to receive those written assignments before you actually begin the next module. Each of the modules, just for your information, will be at your agency, and you can access both the modules as well as the related handouts at your discretion. At the end of the entire course, there will be a post test, and there will also be a one-to-one phone consultation that you'll have with me. We'll schedule that based on your individual preferences. And all of the work, again, is going to be sandwiched between today with final completion of everything no later than September 15th, 2021. When you've completed all of the lectures, you've completed all the written assignments, you've completed the post test, and we have had our telephone conversation, you will then receive a certificate of completion for the coursework that you've completed. So my preference for those of you that have been in training with me in the past is always to have our trainings be experiential, and the technology of teaching the class by Zoom limits us to some degree to at least be able to have conversations together. However, I would like to begin today's session with a case that really reflects much of what it is that we're going to be covering in our upcoming times together. The case is Corey. You have Corey on the screen, both available to you on the screen, but you also have Corey as a handout. I'm going to read through Corey's case, and what I'm asking you to do is, as I read through Corey's case, I would like you to begin to determine, first of all, very informally, whether or not you think Corey is presenting with a substance use disordered issue only. Do you think Corey's presenting with a mental health disorder only? Or do you think there's a possibility that Corey might have these conditions running simultaneously? So again, if you'll follow along with me, Corey is a 25-year-old male. He's been referred to a pre-placement assessment by his social worker. And his social worker has now reported that he has failed to both follow through on any scheduled appointments, both for housing as well as healthcare needs. Corey also recently acknowledged to his caseworker that he has been using marijuana on a daily basis. Just some background information. Corey's parents were divorced when Corey was 12. Corey said he started using marijuana when he was 13 and he used with friends from school. He stated that it always made him feel relaxed and comfortable. On one occasion, when he was 17, Corey told his mom that he felt really happy, full of energy, and that he was going to design a new fighter jet, which he was sure the Air Force would want to buy. He stated that this would make him a millionaire and he could support his mother and buy her a new house and she could stop working. Shortly after that, Corey was hospitalized, and after 1 week in the hospital, he was then referred to a local community health center for follow-up treatment. Although Corey met and liked his case manager and his psychiatrist, he didn't remember why he had been hospitalized. He didn't remember what led to his hospitalization. He wasn't convinced that he had a mental illness, and so he quit going to treatment after only a few sessions. Corey was prescribed some medications, but he didn't take them regularly. After about 2 months, he quit taking them altogether. Later that year, he told his mom that he was worried about people stealing his plans for the fighter jet and was obviously upset and agitated. He continued to smoke marijuana daily and said he needed it to relax. He used to smoke with his friends, but he states because they've turned against him and tried to get him, he's begun to smoke at home by himself in his room. Corey had a number of additional hospitalizations when his social worker suggested there might be a connection between his use of marijuana, his failure to take his meds, and his hospitalizations. Corey strenuously disagreed and said he would continue to smoke because that's just who I am. He also denied that he needed any drugs for his brain. After completing high school, Corey's life deteriorated. He worked a series of jobs that never lasted more than a few months. He attributed that to his poor concentration and his difficulty getting along with his coworkers. He became isolated from his family and friends, staying in his room and smoking marijuana all day long, only going out to get more of the drug. Corey's mother has been supporting him. She gives him money twice a month to get things such as clothes and bus tickets. He uses the money to buy marijuana. He hasn't worked for the last 2 years. Although Corey now remembers his last hospitalization, he states that he didn't get any diagnoses and he just doesn't need help for anything. So that is a case that certainly brings to bear some substance use data, certainly brings to bear some symptoms of, at a minimum, possibly anxiety, some paranoia. Again, drug induced, we don't know. Is the paranoia more as a result of his anxiety? We may start to have some indicators of possibly some personality disorders. That'll remain to be seen as we get more into our diagnostic work in upcoming sessions. But he is certainly isolating, not able to maintain any kind of a stable job. And it seems now that his entire life is evolving around both his delusional thinking and then also his marijuana use. Typically, what we would say about Corey in the past is this a chicken or the egg phenomenon? Did the mental health come first and then the substance use? Did the substance use come first and that exacerbated the mental health? Are the mental health symptoms in any way part of withdrawal? Now that he would consider the possibility of not using, might we see some of these mental health symptoms just virtually explode? That's the kinds of things that we will be addressing in this training. Co-occurring, running simultaneously, mental health and substance use disorders. Now, what I'd like to ask you to do is to take a look at the next set of handouts. It's the PowerPoint presentation. There are a few things I want to highlight as we take a look at uh, again how the sessions are going to unfold, how our meetings together are going to occur, and so on. So again, you see the title, Serving Clients with Co-occurring Disorders. We do have some problem statements that I think are also very important to look at. So if you'll turn to the second page of your handout and look at the training problem statements, these are the problem statements that really are going to be addressed in the 12 hours that we spend together. The first is that co-occurring mental health and substance use disorders constitute one of the most pressing problems facing behavioral health professionals today. I'm going to go into more statistics later on as we wrap up our session today, but let me just emphasize that first problem statement. It's estimated that 80% of the individuals who present with substance use disorder are also at least presenting with what looks like mental health disorders. At a minimum, they're depressed, they're anxious, they're concerned about what's going to happen next. If they've had any legal issues, they're concerned about their legal consequences. They may be concerned about some of the impairment that they might have caused in their relationships, in their family, to their jobs. So again, substance use disorder clients presenting with mental health like symptomologies is not at all unusual. On the other hand, we take a look at those individuals who have had legitimate mental health diagnoses, and we see an interesting phenomenon with them as well. They may well have gotten a mental health diagnosis. They may well have seen a psychiatrist. They may well have been given medications, but they're not pleased that their symptoms have not immediately eradicated. Again, an unrealistic expectation of medications and therapy, but oftentimes that is the client's assumption. I'm now dealing with this. Why don't I feel better? Well, if I'm not going to feel any better, I'm not going to take this medication. Or sometimes we have the reverse apply. I'm actually am feeling much better and I can just quit the medication. Again, another discussion for later on in our course. Let's go back to the scenario where the medication seems not to be giving the client what they're looking for. And as they struggle with their mental health symptomologies, they become aware of substances like alcohol or recreational drugs or other medications other than psychotropic medications that at least temporarily bring them some relief from their symptoms. So rather than using their medications, they're now using, as I said, alcohol, recreational drugs, or other medications to the extent that over time there's a very high probability that they could also develop from those substances, if not a psychological addiction, certainly a physical addiction, a compulsive use of those substances in an effort to try to medicate their psychiatric symptoms. Hence, mental health professionals are going to see substance use clients. Substance use clients are also going to see mental health clients. How pervasive is this across the country? Well, it's estimated that close to 10 million people in this country experience at least one mental health disorder. That means a diagnosable mental health condition in combination with a substance use disorder, either mild, moderate, or severe. Just a reinforcement again of the pervasiveness of both substance use disorder and mental health across the population. And again, the probability that you're going to be seeing them coming to you for comprehensive assessments for treatment, and so on. Which brings us to our third bullet in the problem statement, and that is encountering a client with co-occurring disorders. Quite frankly, oftentimes leaves the provider in quite a quandary as to how best to address these needs. If I'm a licensed alcohol and drug counselor, then my lane is alcohol and drug counseling. I ought not to be doing any mental health counseling. Some individuals may have mental health licenses, but they've been hired as a substance use disorder. Therefore, that's the only thing they should be dealing with. Conversely, a mental health professional may, in fact, have some background or training, possibly even a license as a substance use disorder. But when they're wearing the hat of a mental health provider, they also ought not to be doing therapeutic work around the substance use issues, but would stay rather with their lane, mental health therapies. Again, reality is that many times providers are called upon to work on issues around which they don't have training, they don't have qualifications, or just the lack of basic knowledge. And that brings us finally to the last bullet, and that is this training. This training has been designed to assist you as a behavioral health professional, specifically as a substance use disorder professional, in addressing the needs of clients that are going to appear in your agencies on your caseloads with co-occurring diagnoses, and ultimately enabling us by collaborating with our mental health professionals to then increase the likelihood of improved service outcomes. There is, by the way, a pretty big umbrella of ethics that sits over all of this. So let me just reference that real quickly. The ethical concerns that override all of what I've just covered with you is, first of all, to do no harm. We do not want to, in our zealousness to serve clients, in fact, do more damage. We don't want them to be worse off after we've had access to providing them services. And that, again, is just a strong reinforcement for why it is going to be so critical that you stay within your 12 core functions as a substance use disorder professional, knowing how to access then the services of the mental health professional. The other ethical parameter that I think is real important as we set the table for our training is our obligation to provide the highest degree of service with the greatest degree of integrity. I'll be referencing those throughout our sessions together, but those are certainly going to be overriding ethical principles. Do no harm and provide the highest degree of service with the greatest degree of integrity as we serve the needs of clients with co-occurring disorders. Now that takes me to the third page in your packet, which is your training goals and objectives. They're very simple, they're very direct, they're to the point. As a result of this training, you are going to get the knowledge and you will be offered the skills that are necessary to work most effectively with your substance use client who is also presenting with behavioral health issues. You're also going to, as a result of this training, know what sorts of resources you might want to use in your skill set. It's not just knowledge. What are the resources, the techniques, the tools as a substance use disorder professional that you want to use, both in assisting the client, obviously, with their substance use issues, but also collaborating with those individuals who can provide mental health services. And then finally, in addition to talking about additional, not only knowledge and skills, but we're going to talk about a variety of resources. Your handout says community resources But I'd like to also emphasize that we will be talking about some clinical resources for your consideration as you're working with clients with co-occurring disorders. That takes me to a little more of an in-depth description for you of the actual modules themselves. Our module today that we're going to be looking at, Module A, is going to focus on basic information, statistics, just a general incidence and prevalence as it relates to co-occurring issues, an opportunity for us to explore some of the myths or misinformation that's out there related to both of these client populations, and also an opportunity for you to take a very candid look. I'm hoping you will be willing to do that, a candid look at what values or belief systems you bring to the table. The second session is going to be much more a modality. We're going to be looking at the model of comorbidity, which came first, the mental health issues, the substance use issues, or as we're recommending to you at this point in time, a bidirectional model. That will all be covered for you in the second session. I'll also be talking about some of the causation factors, not only for mental health disorders, but some of the causation factors as it relates to substance use disorders in the second session as well. And then in sessions 3 and 4, we are going to actually go into the major diagnoses that as a substance use disorder professional you might encounter in the work that you're doing. It is very likely that as you're working with clients, you're going to encounter mood disorders, anxiety, and depression. We will talk about those in session 3, the incidence and prevalence of those occurring with substance use disordered clients, just a little bit of the diagnostic definitions out of the DSM-5 for those disorders. And then what might you do as a substance use disorder professional, staying in your lane? What might you do in your clinical strategies to assist that client? And then in session 4, we're going to continue with that format. In session 4, we're going to look at manic depressive or bipolar disorders. We're going to look at personality disorders, the antisocial personality, and the borderline personality disordered individual who also has substance use issues, and what are going to be some of the challenges that you might encounter when working with that individual. Just to speak to the broader picture again, as you're going through the various lecture modules, after today, the rest of the lecture modules will be available to you. If there's anything that you hear in the lecture module that's not clear to you, anything that I say that, quite frankly, you want to take exception with, please communicate with me. You do have my email address. That is available to all of you anytime during our 4 sessions, not only as it relates to the content, but also to the homework assignments that you're going to be getting with each session as well. So what that does now is it takes us into this arena of mental health myths and facts. There's a lot of stigma. There's a lot of preconceived notions out there that people have related not only to individuals with substance use disorder, but there's also a lot of stigma, preconceived notions, judgments, biases that people have related to mental health issues as well. And I'd like to just highlight several of those in anticipation of getting you ready to take on your homework assignment. First of all, there is this belief system, erroneous as it is, that if I don't know somebody with a mental health issue, then don't tell me that this affects everybody. it does affect everybody in some way, shape, or form. The incidence and prevalence is much more rampant than what we might realize. 1 in 5 Americans experience a mental health issue at some point in their life. 1 in 10 Americans experience major depression. We have certainly seen that as a result of what has happened to all of us in the last 18 months with the pandemic. The anxiety and the depression has increased exponentially across our populations. 1 in 25 Americans live with a mental health diagnosis that is serious enough to be considered serious, persistent, and chronic. And these individuals are obviously going to have challenges, both managing their mental health issues, but they're also going to need some special approaches as it relates to managing their substance use disorders as well. How can I say that this affects all of us? It affects our communities. It affects the people that we know. It could potentially be affecting a loved one of yours. We certainly need to be realistic about the resources that are needed, the funds that are needed to be able to assist these individuals in living quality of life, both in recovery from their substance use as well as their mental health issues. One of the myths is that children don't experience mental health problems. They do. As a matter of fact, children are very vulnerable. Even very young children can show early signs of serious mental health disorders. I had an opportunity several years ago to have a retainer contract with the state of Washington around suicide prevention. I went to the state of Washington every month for a year, talking about suicide prevention strategies, working particularly with educators in how to recognize and respond to that in the school setting. And one of the stories that was shared with me as I was visiting a particular community in the state of Washington was the story about a little boy, 3 years old, who at the age of 3 was verbalizing wanting to kill himself, wanting to be gone, not wanting to be here ever, ever, ever again. You can only imagine how disastrous that was, how painful that was for the family. But it was also something that oftentimes the providers would look at him and say, well, he can't possibly be suicidal. And by the age of 4.5, yes, that little boy did complete suicide. He stepped out in front of a city bus. His mother let go of his hand for just a moment. And he stepped out front of a city bus and he died. So again, yes, a tragedy. Children have trauma. Trauma can impair them as children with various kinds of mental health symptomologies. Unresolved, as we know, trauma can also now linger over into their adult years. As a matter of fact, let me just talk about trauma for a moment, because this is an issue that has since been added to the initial legislation requiring you to have the 12 hours of co-occurring training. The Alcohol and Drug Abuse Division has now added to the requirements that within our training together, we do add some discussion on recognizing trauma, different than post-traumatic stress disorder, still falls within the anxiety domain, but how to recognize trauma. Unless we have been specifically trained and certified to do trauma work, we ought not to be doing that. We ought to be referring that to individuals who have those credentials. But it is now something that does need to be discussed in this training. We'll talk about it next session. And then also Department of Human Services Alcohol and Drug Abuse Division added needing to emphasize again person-centered care. The client with co-occurring issues is very, very, very complex. What might present as symptoms today may not look like symptoms tomorrow. What might not look like a symptom today could be exacerbated by their substance use tomorrow. And the complexity of these clients then tell us how critical it is that we really have individualized care plans, that we are sure to be focusing on the specific cognitive, intellectual, emotional, and behavioral stability of that individual and create treatment plans according to that. And then also treatment plans that are going to speak specifically to their substance of choice and what recovery strategies we're going to use for each and every client that we're working with in our substance use disordered programs. Another myth is that people with mental health problems are violent, that they're very unpredictable. Well, I with a tongue in cheek, and forgive me, I don't mean to be sounding sarcastic, but tongue in cheek, if you were to stand between a coke user and their substance and tell them they can't have their substance anymore and that you're going to take it away from them, we will see violence and unpredictability. The reality is that, yes, there are certain mental health disorders that leave us with different kinds of behavioral manifestations, some of which are not predictable, but we need to know how to calm those situations as they happen in our treatment centers, know when the situation has now escalated to such a point that we might even need to remove the individual temporarily from the facility, possibly even to a psych facility to get them stabilized, but certainly not to treat the mental health issues. You're going to hear me, you'll be so tired of hearing me say that by the time we finish four sessions, but I just feel a real strong need to continue to reinforce substance use disorder professionals. Clearly, you have your expertise. As mental health professionals, clearly they have their expertise. And we're working with the client population that really needs the collaborative efforts of both of those individuals. Back to the issue of violence for a moment. Here's a fact, it's not a myth, but individuals with mental health disorders are more often than not victimized by the violence, the exploitation, the bullying, the insensitivity of other people. One of the places where other people have slurred speech, where other people may have some mobility impairments, where somebody might feel maybe a little less abnormal if they have a mental health issue, is quite frankly a bar. So now here we are at a bar. Somebody has now decided to take advantage of that individual, their mental health impairment, verbally assault them, and unfortunately sometimes physically assault them as well. One of the misconceptions is that if you have a mental health disorder, it's just way, way, way too much to expect of you to be able to manage a job. So people with mental health issues are generally unemployed. Well, that is not true. That is absolutely not true. Last month, the month of May, was Mental Health Month. And if you were watching any of the public service announcements on TV, people were talking about very meaningful lives, making significant contributions to their communities, being responsible, participating members of their communities, being able to hold down a job. Again, that is not true. People with mental health issues are not unemployable, and people with substance use disorders are also not unemployable. Stigma may make it difficult for them to find a job. Well, we don't want to hire people who have that history. We don't have the resources here at our workplace to be able to manage uh, those mood swings. Again, that's discriminatory, and we've got a long way to go in terms of our workplaces becoming more equitable, not only for the substance using client, but also for the client with mental health issues. Individuals, another myth, individuals with mental health disorders just need to get over it. Just get over it. Just pull yourself up by the bootstraps. Stop this ridiculous behavior. And of course, that's one of the things that's oftentimes said to our substance use disordered client as well. And the part that we overlook is if they could, they would. If it was just a matter of, I'm not going to do this anymore, and I want to willfully remove this impairment from my life, people would. They're suffering. This is not what, who, how they want to be. But the misconception is that they're bringing it on themselves, that they just need to stop the ridiculous behavior, that we need to quit enabling them. We need to quit making excuses for them. We still need to hold people accountable. Yes, we need to hold people accountable to their mental health recovery and their substance use recovery, if in fact that is where they wish to be. But we also have an interesting challenge where, if we're talking about the contemplative change model, readiness for change, dimension 4 in the 6 dimensions of the American Society of Addictive Medicine, we are going to have individuals who have not yet reached that level of awareness. And we have an obligation to provide them quality care, just as we have an obligation to provide quality care to the individuals who are much further along in the change model. Again, just focusing back on some of the client-centeredness issues. One of the myths, it's a pretty heavy hit on us as helping professionals, whether it's as a mental health professional or as a substance use disordered professional. But one of the myths is the more we try to help them, the more we are enabling their impairments to continue. And that is so not true. Well, if I keep doing things for them, they're just never going to recover. They got to suffer a little more. Believe me, they have suffered plenty. They have suffered plenty. Whether it's a mental health issue or it's a substance use disorder, we still need to be compassionate. We need to be empathetic. Whether we're talking about the client with mental health issues, or the client with substance use disorders, or the client with co-occurring, in reality, we have one product to sell. We have only one one item in our store, and the one product that we have to sell is hope. That we can assist them, provide them knowledge, provide them skills, so that they can reach a level of awareness where they begin to see that life could be better. Unfortunately, many times our folks are so downtrodden, and we do that as well. The community does that as well. You're just a loser. You're never going to amount to anything. But to continue to instill hope, empower them to grasp the ring of hopefulness that things could, and in fact, will be better if they are only willing to embrace recovery. Now, that's just a list of just a smattering of myths and misinformation out there as it relates to substance use disorder. And what that does is it now sets the stage for me to review with you your 2 homework assignments. We're going to stay on this concept of myths and misinformation. And I would like you to look at, first of all, your handout. It's called Man on the Street, Man or Woman on the Street. And as you read the instructions on your handout, what you see is imagining that you are now a reporter for a major television station. And you've been sent on assignment. Our tech people are going to get our Man on the Street document up for us. You've been sent on an assignment to interview people. Go to your local mall, take a drive up to the Mall of America. Here we are. We got lots of people around us. And we're going to begin asking them if they would be willing to spend a few minutes and visit with us. And for those people who agree to do that, not everyone will, but for those people who are willing to participate in our interview, we are going to begin asking them, what are some of the general stereotypes, stigmas, words, inaccurate information out there that people use to describe alcoholics or addicts? We aren't looking for the nice words like they're in recovery and they're going to meetings. No. We're talking about the stigma, the stereotypes. Man on the streets, belief systems as it relates to individuals who've been identified as alcoholics or drug addicts. I use those words specifically. I didn't use the word substance use disordered because even those words are oftentimes the stigma. Oh, you're an alcoholic. Oh, you're an addict. And people immediately flash all kinds of pictures in their mind as to what it is that means. I'd like to ask you to try to come up with, 10 stereotypic impressions, stigmas, myths that you believe people have about alcoholics or drug addicts. But you're not done. Then I would like you to also continue with your Man on the Street interview. And I would like you to then begin asking people what words they would use to describe what their belief systems are, what their stereotypes or stigmas are as it relates to people who are mentally ill. We aren't going to say have mental health concerns, they're mentally ill. So we're using the terms that themselves are very discriminatory. Now you'll have some things on the alcohol addict list that you're also going to have on the mentally ill list. But again, I would like to ask you to try to come up with as many diverse examples, man or woman on the street, as it relates to stigmas around alcoholism, drug addiction, and mental illness. But you have a second assignment as well. You have 2 written assignments. The other assignment is entitled the labels activity. Let me describe it to you, and then hopefully it'll make sense. And if you have any questions, again, just shoot me an email. I'll be more than happy to clarify the assignments for you. But here's the scenario on the labels activity. If in fact our clients had a choice as to how they would be labeled, if our co-occurring disordered clients could choose to be labeled mentally ill or addicted or alcoholic, which of those labels do you think they would prefer, and then why? Just write a paragraph, your thoughts and impressions. Think about your clients. If your clients had a choice to be labeled as either substance use disordered, alcoholic or addict, or mental health disordered, mentally ill, which of the labels do you think they might prefer, and then why? So that's the other assignment. Let me just review our format again. Any questions about anything I've said today? Any disagreements? Any things that you want to add to the discussion? I would welcome to receive emails from you. And then any questions or clarifications that you might need as it relates to your 2 written assignments. I also am more than willing to talk with you about those. And then to just review our format, if you finish those written assignments, then send them in to me, email them to me, Karen@edensgroup.com. I'll critique them. If there's any feedback, I certainly want to provide you some feedback on your written assignments. And then at that point, you want to go into the next module. You want to view the recorded lecture in the next module, and then you will also have homework assignments for that module as well. So that wraps us up for today. Look forward to our next time together. Again, any questions, comments, send them my way. Thanks for being with me, and stay safe and stay well. Thank you.